got that biopsy, and thanks for supporting that. And we hear a lot now about genetic sequencing of those biopsies. What is it, from your perspective, what's the value?
At this very moment, it's about inclusion in clinical trials. We've got these c-Met inhibitors, and tumatinib's one of those drugs that's in that class. So if I want my patient in that trial, I need to have tissue. And if I don't get tissue before all the ablation steps start, I may have trouble actually getting sufficient tissue to get them into a clinical trial. So that's just a first practical stage. We talked about making sure we have the right tumor type. And then the future therapies are coming. We have all these receptors, we have different signaling pathways, and I would like to know, if I was a patient, what's the profile of my tumor? I know that there's 500 clinical trials and 20 new drugs coming out. I'd like to know my baseline profile, and that's what I'm advocating to my patients.
Fair enough. Richard, are you doing it at CLA, and in what kind of setting?
Look, unfortunately, we still approach liver cancer as one size fits all, other than stage. You have this disease, you get sorafenib. We know there's been excellent molecular profiling studies done in liver cancer that parallel breast cancer as far as defining a molecularly heterogeneous disease. One of these profiles is actually being now commercialized for patients who were resected to predict their risk of relapse. But as far as selecting patients for therapy, it's not there yet. Certainly, the next generation of clinical studies, given the failures highlighted by Dr. Geschwind, we need to move to a more personalized approach to this disease, one that takes into account this molecular heterogeneity and identifies predictive markers for response. To date, the studies that have been done, which have gone against sorafenib has certainly stood the test of time. I can't believe it's 2015 and we've only had more studies that support sorafenib's efficacy, right? Although most of the agents that have gone up against it have been similar class. They've been multi-targeted tyrosine kinase inhibitors that hit VEGFR plus something else. There is still one phase 3 study head-to-head, the lenvatinib study, that is, I think, if negative, would probably be the last multi-kinase VEGF head-to-head versus sorafenib, and it's time to move beyond that, and we are.
Absolutely, and there are different ways of moving beyond, and we're talking still about first-line therapy. Other than what Richard just mentioned, there is the phase 3 trial, which is NCI-sponsored 80802 CLGB, which looking at sorafenib versus sorafenib plus doxorubicin based on data that we published from a group in a cooperative fashion that actually showed some improvement in outcome for the doxorubicin plus sorafenib. This, however, should remain within the realm of clinical trial. That trial hopefully will continue accrual. Same thing, the plea that I passed on when we talked about ECOG 1208, accrual on clinical studies, especially on national studies, is very critical. That's one approach, to kind of look at the combination like the doxorubicin, but definitely the other approaches is to look at different mechanism of action. And I come to the second line therapy because I think this is really where the meat of the matter is. And I think in the second line we did better by differentiating many different mechanism of action. And let's start by talking about the c-Met, and maybe Richard, you can take us through the 2 clinical trials currently ongoing for c-Met inhibition.
Right, so c-Met, or the hepatocyte growth factor receptor, certainly sounds like it should be important in HCC, and certainly there's data that supports that. There's a lot of lab data that suggests that it's circulating ligand, HGF, or hepatocyte growth factor, may play a role in the pathogenesis or alterations in the receptor. It's a receptor tyrosine kinase, like many others we target in oncology. Probably the most provocative data came with tumatinib, which in a randomized phase 2 study took all comers, second line. So these are patients who have progressed on sorafenib, which is a whole other discussion about what is sorafenib progression. But patients who were felt to be progressing on sorafenib, and they were randomized to tumatinib or placebo in a blinded fashion, and overall the study did not show any benefit. Retrospectively and planned, they analyzed patients' tissue for c-Met expression by immunohistochemistry. At the time this was done, there was still a lot of excitement about c-Met and lung cancer, and assays were developed, and they showed that there was really 2 things that came out of that. One, if you were c-Met high, you had a bad prognosis in the placebo group. c-Met high versus c-Met low, you did poorly. However, in that group that was c-Met low, those who had gotten tumatinib had a significant improvement in overall survival, and that's led to probably the first biomarker-selected study in HCC. A phase 3 study randomizing patients, tumatinib versus placebo, after sorafenib, but only if you stain high for c-Met. And the results of that study will be eagerly awaited. Cabozantinib is another c-Met inhibitor that was analyzed in a randomized discontinuation study that has moved now into a similar design. However, they are not selecting for c-Met, but again, a second-line population.
Yeah, actually, we are not selecting for c-Met. Actually, I lead that trial, and there's a little bit of philosophical approach here in regard to c-Met expression. Being a multi-kinase inhibitor with other virtues like anti-angiogenesis as well as others, we took a lead on doing cabozantinib and offering it to patients without any reference to their c-Met. Of course, we are testing c-Met in the background of correlative study, but it's different philosophy from the tivantinib group that I think is led by Dr. Love from the Barcelona group, that looking specifically at c-Met expression being high as 50%, 3 to 4 plus among those cells. It's a view. I would say we have to wait for the data until we see where this takes us. There are many other studies that unfortunately so far has been reported negative, the latest of which is ramucirumab. There is mTOR inhibition with everolimus, and I think there are some other studies still ongoing which we are waiting for the data from, like ADAPEC 20, which is a arginine deaminase inhibition approach. No doubt that we are seeing different philosophies in regard to how to treat in the second-line setting. And the nice thing is that there's a lot of trials ongoing, which we encourage, of course, always that you seek those trials before trying to attempt things that are not necessarily tested or approved for that purpose. But Richard.